Everybody hear me all right? Okay, we switched the order of these two talks. My former colleague, Dr. Bloom, who is going to talk about more of the adult problems of the heart and the aorta that we deal with. And I'm going to do the pediatric. Both of us actually do both children's and adult aortic surgery. As you heard, I work now at Johns Hopkins. I've been there for 40 years, since 1984, except for the 5 years that I spent working with Dr. Bloom and Patricia and others at Mass General, some of the 5 best years of my life. So and these are pictures, actually. That's the original building of the hospital, 1889. It's called the Dome Building, and then there's a newer part that was added there. But that's where I work. So let's see.
Try now.
There we go. Our disclosures. Well, if you look at the web page for the APTA2 Alliance, you'll see a nice little overview and description of MSMDS, like all of you know. But there's this beautiful paragraph there that reminds us that the 3 hallmark signs of this disorder are patent ductus arteriosus or aortopulmonary window. And my talk is mainly to explain what those 2 lesions are and what the effect they have on the child. The other 2 problems, as you know, are the mydriasis and the white matter changes of the brain. But this is really just to focus on these 2 heart lesions, so you could just better understand what the ramifications are of this. You know, I was surprised actually reviewing for this that this disorder's been known for over 25 years. But progress is slow with rare diseases. It takes you sometimes decades to learn the whole spectrum of the disease. And then we start to work on the best ways to treat them. But the syndrome really wasn't fully characterized until about 10 years after that initial discovery. But still, a disease that we really need to learn much more about. So it's worth taking a minute to just talk about a normal heart and how it works. And these are just pictures of a typical heart. Hearts really do look like this. And by the way, it's right after lunch, so I'm not going to show you any video. But the heart does look just like that, except the colors are all wrong. There's no bright red, bright blue, and dramatic browns and yellows. The heart really looks like a steak because it's a muscle. And but that kind of appearance is the way it looks in the operating room. And on the right is as if you took the front wall of the heart off and looked inside. How many of you were told in grade school that the heart is the size of your fist? Right? It's wrong. It's 2 fists, and it's actually 2 pumps that sit side by side. And you see on the right side, sorry, I don't have a pointer. There are 2 pumping chambers. They're called ventricles. The one on the right side, and we always refer to it as the patient's right or the patient's left. It's never the way it looks on a picture. It's always the patient's right or left. But the right side of the heart receives blood from the body, and then the right side pumps it out to the 2 lungs. And the blood vessel that takes out there is called the pulmonary artery. That's shown in blue, just to symbolize that that's the side of the heart where the blood is dark, because all of the oxygen has already been extracted from the blood as it passed through the body. And the heart's main role is to deliver blood and oxygen to all of the organs of the body. Well, after the blood picks up oxygen, it does turn bright red, and it comes back to the left side of the heart. And the left side then pumps it out to the body. There are these 2 then major blood vessels. The one on your left, patient's right, is the aorta. That's the biggest blood vessel in the body. It's about 1 inch in diameter. It comes up and turns around an area called the aortic arch, and then comes down behind the heart. And all of the branches of the aorta supply blood to every organ of the body. On your right, patient's left, is the pulmonary artery. That's the artery that sends the blood out to the lungs to get oxygen. So the heart is two pumps, and they're actually in series. That is, the blood goes through the right side first, goes to the lungs, comes back to the left side, and then it's pumped out to the body. And that arrow is just to point out that first structure there. It's a little blood vessel that connects the aorta to the pulmonary artery. Now, in an adult, it's a very, very tiny blood vessel, and often it's not even open anymore. But that is called the ductus arteriosus. It's a connection between the aorta and the pulmonary artery that we all are born with. And in fact, while the baby is still in the womb, in the uterus, all of the blood from the right side of the heart doesn't even go to the lungs. It goes through that blood vessel and out to the aorta. It's because the baby isn't breathing. There's no air exchange in the lungs. So it's kind of like a pop-off valve, or it lets the blood coming out of the right heart just go right on out into the aorta and to the rest of the body, because the baby's not breathing. The minute the baby wakes up or is delivered, takes a deep breath, and now the lungs are filled with oxygen, that blood vessel called the ductus starts to squeeze off. And so we're all born with the patent ductus, all of us. But somewhere between a few hours to a few weeks later, that blood vessel closes off, constricts down, and then all of the blood from the right side of the heart gets directed to the lungs. So that's a patent ductus. But patent just means that it's open, but as it closes off, which is what happens to almost everybody, then you have the normal circulation of an adult. But there are times when that blood vessel can stay open when it shouldn't. It happens much more often in premature and small birth weight children. And I'll talk in a minute about why that's a problem. But I'll also talk about the aortopulmonary window. Now, here the situation is a little different. It's not that little blood vessel that we all start life with that connects the two. This is where the aorta and the pulmonary artery, which sit right next to each other, actually are fused, and there's a hole, there's a connection between the two where they shouldn't be. That's not normal. That's a rare problem, and it's called an aortopulmonary window. So it doesn't perform the same function that the PDA does in normal life, but when both of these or either one of them is present, the problem after they're born is different. And by the way, there are different kinds of aortopulmonary windows. Scientists love to divide things and classify and give them all new names and numbers. It actually doesn't matter a lot unless you're actually going to do the operation to fix this. But most of the time, the physiology, the impact on the circulation is the same for all these different types. So it's not really important to know that. But why is a PDA or an aortopulmonary window a problem? Well, it's because when blood comes out of the aorta or out of the heart, goes into the aorta, if there's a patent ductus, then the blood will run from the high pressure aorta back through the ductus or the AP window back into the lung artery instead of going out to the body. So I'll say that one more time so that all sinks in. If you have either a patent ductus or an AP window, when the blood comes out of the heart and goes into the aorta, a lot of that blood leaks right back through the PDA or the window, and it results in too much blood going through the lungs because you have that leaking back, but also the part that's coming up from the right side of the heart and going in there. So the anatomy is different between these two, but the impact is the same. You have too much blood going back from the aorta into the lungs. You have too much blood going through the lungs, and the lungs are as thin and delicate as a sponge cake. But if you have too much blood going through them, it becomes like a wet sponge, and the lungs get soggy and stiff, and the children can't breathe. They have stiff lungs, It can affect their oxygen levels, and they can spend so much time and energy pumping all this blood through the lungs that they actually burn their calories that way, and they don't feed well, they don't gain weight, and they can actually even be overwhelmed by infections that result from the congestion of the lungs. So both result in too much blood flow to the lungs. And it depends how big the connection is. If it's a big ductus or a big AP window, you may have these problems within a few days of birth. If they're small, you might actually live a few months or years without a lot of problems. So it also depends then just how big these connections are. Even if you don't have this failure to thrive, if you're not feeding, growing, such, there are some late problems that can develop. The lungs, blood vessels can be damaged by too much flow. That's what pulmonary hypertension is, when blood pressure is too high in the lung arteries because the blood vessels have been damaged by excessive flow. And then even infections of the heart valves can occur if you have too much blood going through the lungs over time. So that's the concern here. And we don't even have good data on how frequent these problems are in MSMDS patients. They're just the population that have been studied carefully is so small. But we do know that with both of these, the way you know that the patient has it is that you usually see that the child or the baby is not growing as much as he or she should, is breathing fast, and they often have a murmur. And that's often one of the early tips. That's why there's a lot of time spent listening to the chest earlier with any baby born, because the murmurs, which result from excessive flow or turbulence within the blood vessels, that's just the noise of too much blood or a constricted blood vessel. But to really make the diagnosis, all you need is an echo, not one of those fancy ones where you put the tube down the throat, just the old-fashioned echo with done on the surface of the chest. You can see these very nicely. Now, if you haven't seen these before, it may not make much sense to you. But that flame of color that you see in the upper right-hand corner of a PDA, that's actually the color represents the flow. And there's a lot of flow with bright yellow color there going through the aorta, back through that PDA. Where the color is that's the PDA. And on the side there on the right is the AP window. And there, of course, this child was probably a little bit bigger. You can see the aorta. That's the AO there, right next to the pulmonary artery. You can get the sense of the way it branches left and right. And you can see the hole there. That's a big aortopulmonary window. This child would have a lot of problem with that. So, how do we treat these? Well, let's talk about the PDA first, because that's a very common problem, especially in small babies. And AP windows, very, very rare, except in MSMDS. But with a PDA, if it's not a big one, you can sometimes get these patent ductuses to close down by giving a medication called indomethacin. It's an inflammatory, it's an anti-inflammatory medicine. And especially in these tiny children, you can see this is that child probably weighs about a pound or a pound and a half. So if it's a small ductus, you can give a medication and these will sometimes close down with the medicine. No surgery or intervention. But if they don't respond to that medicine, or if they're too old, the medicine doesn't work well outside of the neonatal period. But if they're older and they've got too much flow from them, there is an operation that can be done where you either clip or tie off or actually divide the PDA and sew the two ends shut. And that operation, by the way, was first done at Boston Children's Hospital in 1938. If you grow up in Boston, you think that that's the first heart operation ever. If you grow up in Baltimore, we have a little different view about it. But I grant them that they did go first. And but by the way, the surgeon who did that, Dr. Gross, was born in Baltimore. So let's call it. So that operation can be done in a child that weighs half a pound. It's a small structure. You got to be gentle, but that can be done. For a little older or bigger child, if there's a ductus, it's possible to pass a wire and a catheter up through the leg artery, go up in there and get the wire across the PDA and close it off with what's called catheter closure device. No incision. It's really, it's amazing. And when it works, it's a beautiful thing because you can go home the next day. There's really no scar, no pain. So which one is the right one to do? Well, it depends how big the child is. But there is always a concern too with MSMDS because the tissues are just so fragile that maybe those catheter interventions, the ones where you're putting a device in weak tissue, that may not be the best way to go, but we just don't know yet. We just don't know. But certainly, if all they have is the ductus, the operation between the ribs on the side is possible. The AP window, I won't talk about it as much, but it's a more complicated thing. The blood vessels are literally fused, the aorta and the pulmonary artery. The hole can be huge. And there isn't just a little bridging structure like a PDA that you could tie off. Every now and then it's like that, but most of the time they are fused. And there's no way to tie it off safely without distorting either of those blood vessels. So here you can see in the upper left, there's the aorta next to the pulmonary artery, and you see these are side to side with a pretty big hole in there. At the bottom left, there was one that was actually small and had a little bridging tissue, and you can ligate those, but that doesn't happen very often. And most of the time, it really requires an open heart operation. You know, an incision here being put on the heart-lung machine, stopping the heart and dividing those blood vessels and then putting separate patches on both sides of the hole, if you will. As heart surgery goes, even in newborns, that's not a high-risk operation. It's a pretty straightforward thing to do. But one of the things we do worry about is again, the tissues are not great. They are weak. And we even worry about the brain because we know that there is a vulnerability of the white matter of the brain. And there are some concerns that being on the heart-lung machine may be more detrimental to the developing brain of children like that. Now, at least now with our level of understanding, we have to accept that risk because this is a fatal problem to have. And if using the heart-lung machine is the only way you can address it, then it's a risk worth taking. So there are some other considerations. Dr. Bloom is going to talk about some of the other problems that can develop, particularly in the aorta, later. These are the ones, the PDA and the aortopulmonary window are the most common congenital heart problems. That is the ones present at birth and probably the most consequential. But aortas that become very dilated and develop aneurysms, that's what Dr. Bloom's going to talk about because that becomes the second wave of threat to their cardiovascular health. And there are situations where sometimes you could have a patent ductus or an aortopulmonary window and a hole in the heart, like an atrial septal defect, ventricular septal defect. And if those need to be fixed at a certain time, then the PDA and the aortopulmonary window can be fixed at the same time. So every patient is different. If there are multiple problems with the heart, sometimes the best thing is just to go in and fix it all, even though that may be an open heart surgery. As I've said, the tissues are friable, and that may make the surgery challenging, but it may also limit the effectiveness of catheter devices and stents and things like that. For stents and those catheter devices to work well, they need a certain amount of strength of the aorta and the tissues around it to hold them in place. So although everybody loves the idea of catheter interventions, sometimes they just don't work very well in patients with weak tissues, not just MSMDS. There's a broad variety of people who just have weak tissues. And I've mentioned too that the use of the heart-lung machine may have some special consideration. But here is what this is what I want. I was hoping that you just have a better idea of what these heart lesions are all about and the impact of having too much blood going through the lungs. But what I want you to remember is that the outlook overall for treating the PDA and the aortopulmonary window is good. These operations can be done safely. Unlike a lot of things we do to the heart, they are curative. That is, if you fix a PDA and you fix the aortopulmonary window, you're usually good for life. With those problems, anyway, you may develop problems with aneurysms or such later on. But these are one of the few things that we operate on in children where we can say it's taken care of now. Low operative risk, and as I say, can be definitive. So summary, PDA, it's the most common congenital heart defect in MSMDS. We don't know about lots of the other problems. We just don't have enough experience to say, well, this occurs in 5 out of 1,000 patients. We don't have 1,000 patients yet. That'll be the importance of this registry that will be discussed later today. Dr. Bloom's going to talk about aortic aneurysms and aortic disease in older patients. And these are really common in these patients with ACTA2 mutations, but they appear later on. It's usually between 10 and 25 years of age. And I think one of the most important points here too is the importance of monitoring. When you know a child has MSMDS, your radar goes up and you start looking for these problems so that you can identify them early. Not wait until a complication occurs, like a ruptured aneurysm or a dissection. You anticipate them, no surprises, have a treatment plan, get your child into the hands of people who have experience with these rare conditions. So thank you very much for your attention.